Hello and welcome to the Doc Podcast. I'm your host, Dr. Mike DeLuke, and it's my mission to help you lead a happier, healthier, and more prosperous life, both personally and professionally. Hello and welcome to this episode of the Doc Podcast. Today, my guest is Dr. Joseph Yousefian. Dr. Yousefian obtained his DDS from Washington University and his Certificate of Orthodontics and Master of Science in Biology and Physical Anthropology from Ohio State University. He is a diplomat of the American Board of Dental, Sleep, Medicine, and Orthodontics and maintains a private practice in Bellevue, Washington. Dr. Yousefian has collaborated on several research projects, including NIH-funded clinical trials in airway and disorders of the temporomandibular joint. He lectures nationally and internationally, has contributed to over 30 publications in peer-reviewed journals and textbooks, and recently released a textbook titled Pediatric Treatment of Sleep Apnea with Teledontics and Telegnathics. And we'll talk much more about what those terms mean during today's show. Joseph and I are in lockstep on the fact that there is a growing disconnect in how healthcare professionals understand and address the root causes of pediatric upper airway disorders. The medical literature is very clear that pediatric sleep disordered breathing can lead to a wide range of comorbidities. Yet many dentists, and sadly, many orthodontists, are resistant to accept that very fact. Additionally, they remain hesitant to embrace the concept that with the correct approach, early airway disease is treatable, and doing so can prevent further complications down the road. We're going to discuss that and more on today's show, including the reason why so many pediatric patients suffer from airway disease to the point that it has become a pandemic, how and why the human skull and jaws have changed since the Industrial Revolution, the importance of getting to the etiology of our patient's malocclusion versus simply treating the symptom, the numerous comorbidities associated with pediatric airway disease, our thoughts on why the orthodontic establishment continues to oppose a more proactive, holistic, patient-centered approach to care, how to collaborate with our medical providers when airway disease is detected, the power of well-timed and appropriate early orthodontic treatment, what exactly teledontics and telegnathics are, and how we can apply those concepts to patient care, and much, much more. Joseph has an amazing story about how he got to this point in his life and career, and the things he is doing in this profession are nothing short of remarkable. It's going to open your mind to a new way to approach looking at our cases, and I'm excited for you to hear this conversation between the two of us. So without further ado, let's get on to today's episode with Dr. Joseph Yousefian. Enjoy the show, everybody. Welcome to Doc Podcast, Joseph.
Thank you very much for inviting me, Michael.
Thank you so much for being here. Many people, I'm sure, probably know who you are, have heard of you. You are a bit of a legend in the field. You've been doing amazing things for many years. Interestingly, though, you've kind of flown under the radar in ways because it's one of those things where everybody in the airway circle and people who think with an airway-focused mentality know who instantly. When I said to people, Joseph's coming on, or people have said to me, you need to have him on your show. Outside of that, I feel like a lot of our colleagues may not know who you are. And I don't mean that in a negative way. I think because you've just kept a low profile and you've been just doing what you're doing, which is changing the lives of a lot of patients. And you're a tremendous innovator. So before we get into some of that side of it, if you would just tell the audience a little bit more about your story. You have a really cool, interesting background and story that I'd love for you to share with everybody before we dive into the sort of content of the show.
So thank you very much for your kindness and the comments that you made. I have been low profile, not that much of publicity. So that's the name of the game. Mm-hmm. So we have been low profile for a long, long time. And now we got lucky because, and when I said that we got lucky because when I say about this, my family and especially my sunshine and my Ryan and my son, which, helped me to develop this technology and understanding. Now we got some exposure because of the book that he helped me to publish and all this thing that comes with it. So, simply, I started my crusade back in Iran. I'm from Iran, born in Tehran, Iran, and I went to Tehran University, and I got my first exposure to orthodontic and dentistry back there. One of the things, Michael, that I got lucky in the beginning is that the program was medical and dental. It was combination. Picking up between which one to go, I loved both. But at the same time, being good as you are, your hand, mechanics, understanding this, I just lean more toward the dental. And then, but the good thing is that I had a great mentor, Dr. Behjat Mugada. Right now, currently, she has been, an instructor at Kansas City Dental School program. And she enticed me so much to go to focus my research on oral medicine, because it was more medicine part of it. But at the time, we had very, very good orthodontic program, and most of them are part American trained and some European trained. So, Michael, that exposed me to how the appliances, the orthodontic, the removable appliances, they work. So I got my first exposure to bionator and activator and right there. So, and then I finished my education, and it was a dental scientist. It was a great opportunity that was given to me. We had 11 department, medical and dental, working on research project. And guess what? We were working on transferring factor by matter. I don't know how. This is 76, 77. And we were looking at the, transferring factor for different reasons. How these, anti-cancerous medications and steroids that they use for pemphigoid, pemphigus, and these cancer, conditions, using this, how is going to impact the transferring factor. But anyway, I got my thesis defended, but at the same time, for political reasons, it was not very successful with my, license there. And I had to come to United States, and I started all over again. And I got blessed again. I went to Washington University. And the reason that is very important to mention this is I got exposure again to orthodontics and, prosthodontics from the view, because they didn't have postgraduate programs and, that. So I got exposure there, and I got some accumulation of information there. And then later I got my degrees and at Washington University in St. Louis, and then got accepted by grace of God at the Ohio State University. When I say that, because Dr. Zev Davidovich, Joe Chanfield, and also Peter Nunn, they were the best thing ever happened to me, because these are research-oriented people. They gave me the opportunity. I was working 3 shifts at the time, up to 2 or 3 o'clock in the morning, working on so many material we created. Michael, I created the CPAP for cells. Can you believe?
Wow.
At the time, they gave me the funding, and I created the CPAP for cells, meaning that we were putting high oxygen and pressure on the cells, and also hypoxia and negative pressure, see how the cells, they do under tension and compression. So we very, very valuable information. But at the same time, 3 years of the program, I got a lot about TMJ under education with Dr. Fox, a lot of TMJ, and the part that was missing is still sleep apnea. We didn't get much of exposure. So I graduated. Again, I know it all. I know TMJ, I know orthodontic, and I can treat everybody. So I think that I broke the record, maybe took my board, and then orthodontic board in the first couple of 2 years after my graduation, and then started doing some successes for stories. And I came to Washington and started practicing in Washington. And then I created a reputation of getting very complex cases. And as a result of that, I was doing lingual braces. I was doing, those very complex cases and TMJ therapy. So I got a reputation of treating complex cases. But at the same time, I noticed that some of them are successful, some of them are not successful, maybe are deteriorating. So I got started, again, my failures opened my eyes and started getting more educated. And course after course. I got more certification that you can believe this. But at the same time, I think that the luckiest thing that happened to my life is exposure to Dr. Bill Arnett. And I'm sure that you're aware of his legendary, education program.
Yep.
And of course, Dr. Gonson later, and then group of people that they were there. And in one of the sessions, again, I got lucky. It's just a matter of luck that I was invited to present at his program, and Dr. Christian Gimino was there. And Dr. Gimino, when we were presenting, and of course, we had some chit-chat along the side, he opened my eyes to what is happening, why my only son, Ryan, was suffering from the disease that at the time I was treating adult patients, but at the same time, we didn't know that much about how pediatric patient they respond to this.
When was this about, and how old was Ryan at this time?
I'm sorry, Ryan at this point, I think that was about 3, 4, 5 years old.
Okay.
But his problems started happening, clinching, grinding. The kid is waking up in the middle of the night, coming to our bed, and his health was deteriorating, Michael, meaning that the kid that was so happy and, full of, life and active in sports and doing great at school, my only child, well, he was doing something weird, waking up, coming to our bed, and then when he's in our bed, fighting for his life. It's like running away from typing, moving, clenching the teeth, and it started having some clicking in the jaws, and the jaw that was small to begin with started getting smaller and smaller, complaining of headaches. And then, now one thing that I learned from one of my best teacher, Dr. Shapiro at the University of Washington, I remember from him that if you don't know and you don't know how to do it, don't do it, because it's going to create more damage. So I didn't do anything, just watch him. And then evolution in my understanding, he started, when he was 12, 13, 14 years old, the disease of obstructive sleep apnea started showing itself, Michael. So I'm sure that you have seen these kids in your practice, become lethargic, become hyperactive sometimes and lethargic at the end of the day.
Yep.
And when we approached the school, when they called us and said that, Ryan actually becoming very disruptive to the school, and is not the same smart kid that he used to be. Now something is changing. And by the way, we are going to put him to a special program, which is going to cost double on the tuition, because he's not the same kid anymore.
Wow.
It is deteriorating and declined. His capabilities, sporting capabilities, was gaining weight. And then the kid that was very, very smart on education, A, B student, now is dropped to C, D, F.
Wow. And nothing else had really changed that much in his life. You're saying it's not like he had any other significant event or illness. He's just slowly turning into a different human.
That's right. And I'm sure that you have seen
I have.
And kids. And then the question is that, let's put it this way. This is a kid that when I'm playing with the PhD advisor at the private school tells me that, I'm sorry, Dr. Yousefian, it seems that something drastically changed, but, don't worry about education, and further education or higher education for him is not that type of quality of person. I said, wow, what the hell are you talking about? The person that is smart suddenly is not capable, something is happening. And so, Michael, it changed my life. And unfortunately, that was very, very upsetting.
Yeah.
So, and my wife is telling me, Joseph, what do you want to do? You have one child. It is the way that it is. We need to deal with it. And I said that, do you know what is not acceptable? The reason that is not acceptable, when my Ryan comes and say, I have a problem with phone, Michael, and I cannot fix my phone. And he gets my phone in 2 minutes, fix it, and said, Dad, how did you go to dental school? You cannot even work with this, and still is doing it. Anyway, I said, you know what? This kid cannot be significantly changing unless he has this, God forbid, severe brain damage that we know that he doesn't fail, he didn't, so, or tumor is growing, something else is
right.
So anyway, now I'm orthodontist, and like you, above average orthodontist. I have a little bit, of medical background. I have great teachers. So I started asking questions, and I started doing, doubting what I was doing. Something is not right. Remember that my patients, some of them, they were not, responding well. Some they were, but Ryan, that I didn't do anything as a treatment, just watch him, also is having some symptoms that some of them has. So when I connected dots, it started becoming more clear. So I said that, you know what, let's look at the airway. I see some of my adults that, they develop the ADD, ADHD mimicking symptoms, become lethargy, memory loss. Are they related? So what happened? Just did the sleep test. Oh, wow. Michael, the sleep test came back that he has 17 AHI, apnea hypopnea index. And they said that, wow, maybe this is it. This is it. Maybe this is the one that was missing link. So not right.
Had you spoken with Dr. Guimino at this point yet?
Yes. That's the time that I started, communicating with Dr. Guimino more. Okay. He said that, Joseph, these are the things that we do. Get the tonsil out. This is what needs to be done. Of course, we need to remember something from Dr. Guimino. He's, he was a medical doctor, a sleep and neurologist, physician, a sleep doctor, one of the best that, can happen. But at the same time, the issue of the TMJ, skeletal relationship, because of the TMJ, still in this communication was not quite there. But told me that, get the tonsil out. Now I need to deal with my family, Michael, a scared wife that doesn't want to do anything drastically. Well, I said, Rosita, my wife, we need to get the tonsil out. Well, Joseph, no, it is going to be too harmful. He said, the kid is suffering from this. Let's get it out. No, let's wait. And you know what? This is important to understand because it's happening to families. They need to, this is a process. This is a process of understanding. So anyway, we waited 1 or 2 summers, and then one day Rosita comes back home crying. And I said that, why are you crying? He said that Ryan had the football tryout, and then they put this heavy gear on the heavy kid. He couldn't move, and he got beat up so much. What can we do? He said that, Rosita, can we start walking toward something that newly I understand? I tried on some of my patients, is working. Let's get the tonsils out. We got the tonsils out, and it was successful. It showed significant improvement. And then we sent him to a very great program, weight loss program 2020 here, and he lost some weight, and he got even better, and education got a little bit easier for him. But at the time, now he's about 15, 16 time, moving fast. So it comes to the point that, 17, 18 years old, Michael, he has a small jaw, and what we are going to do, and now the question is that, yes, we bring his jaw forward, and that is going to solve the issue of the airway issues, because at the time we knew, MMA surgery and jaw surgery is going to impact. We didn't know that much about the expansion impact at the time. So we, discussed that. And by the time also I had a great pleasure and honor and luck to work with great surgeon, Dr. Trimble here. We were going to Dr. Arnett's program. So we decided, okay, let's do the surgery. At the same time, not do the double jaw surgery versus one jaw surgery. Of course, mom doesn't want intense work. So we decided to, and also Ryan is scared. Listen to mom. Let's do just the lower jaw surgery. He got improvement. And the kid that Michael, this is important. The kid that they told us is no good for education. After this, all these things changed his life. This is the problem that we had. When the kid becomes in this situation, overweight, losing interest in education and sports, now it becomes a target. Students, they don't respect him, make fun of him. The administration of the school, they treat him like not a smart person. After a while, the student gets this, unfortunately, brainwashed that I'm not good enough.
Right.
You know, Michael, this is the story of 1/3 of population of human beings.
Yeah.
I mean, still in civilized countries and industrialized countries that they suffer from this disease presently, and they become high school dropouts.
Yep.
Think that I'm no good for education. They're bothering me. Why should I go to a school? And they, drop out of the education. And that's the evolutionary thing that is happening. And we are going to talk about it. So what I did, we started telling Ryan and convince him that this is a problem that your disease of sleep apnea is creating. We solved the problem. So it, is not just the structural correction of the problem and removing the obstructive sleep apnea, is the mental attitude, Michael, that we need to convince these kids, you had the disease, we eliminated.
Yep.
They told you that it is what, you're not good for education and doing important thing is not right. So then it took long time. We convinced him that he's smarter than me and I'm not dumb, because I went to dental school based on my mentors' input that you need to have at least IQ of 120 above to be able to go to dental school. So that convincing took a long time. So he went to, higher education. He got his, bachelor. And then guess what? The kid that said that, they said that, well, you need to be hesitant to get him invested in the higher education. He got a scholarship with Washington University, and he got in. And when he got to the program, I'm not bragging, Michael, but this is the evolution that happens in these kids. That they told us, and parents that are listening to this, doctors that are listening to this, the life-changing that this strategy and this understanding, and Michael, you experience it in your practice, is a life-changing. That they told him no good, and now he's getting a scholarship from prestigious university. And you know what? He got so many awards that compensated for the tuition that we paid, and he paid over $100,000 over the tuition from awards that he got in that.
My gosh, wow.
Of course, he presented, his concentration at the time was what we are doing, the technology that we are doing, and he won so many awards from presenting this. But that's the story that I got exposure to this, and of course, that was the beginning of it. Now, I mentioned about the evolutionary thing that this is doing it. So,
and before you go there, just if you don't mind, I would just like to personally add a little anecdote. Ryan, with whom I've communicated in between talking with you and talking with Ryan, and reached out to me initially about speaking with you because he had heard some of my content. What an amazing young man. And when you're describing who he used to be, who obviously I didn't know, it doesn't even sound like the same human being. And I think that's the most important thing that you mentioned, which I just want to underscore. It's not the same human being. He is a different person today than he was however many years ago that was, because he's resting, he's sleeping, his brain and his body can function appropriately. And I just want to drive that point home to people listening, because so often many of our colleagues question why people think like you think or I think on this topic. And this airway is not a thing. And sadly, our professional organization and many academic institutions in orthodontia don't believe in a lot of what we're saying. And maybe they've just been blessed that they've never had a family member suffer from something like this. Or maybe their family member has suffered and they just didn't do what you did, which was pursue more answers. They just kind of said they are that way. And again, how blessed Ryan is that you were his dad and kept looking for answers, and being the innovator that you are, you weren't satisfied with just letting it be. I mean, Joseph, how many parents don't have that knowledge that you have and ability and just do let it be? And how many of these kids suffer into adulthood, and it, like you said, just ruins lives? And I just guess I don't know why we're not doing more. I'm not to go too far into this, kind of just putting it out there almost hypothetically, just why we're not doing more as a country from a healthcare perspective to try to address pediatric airway. Pediatric airway disease. I don't know. I mean, maybe someone's listening to this who can shed some light on that, but yeah.
Well, the thing is that, Michael, to answer that specific thing is it is knowledge and educational process. Mm-hmm. So, okay, let's have you watched the movie Moneyball?
Yeah. Yep.
Yeah, I love that movie.
Yeah.
There was one scene that I think that the owner of the Red Sox is talking to this coach and say that, when you want to change the game and everybody is comfortable with it, and of course is the lack of understanding of knowledge. So changing the paradigm is very, very difficult, because everybody is comfortable and making money the way that is, and they set up the strategy the way that everybody is comfortable.
Yeah.
Well, when you try to change the system, there is a lot of resistance.
Yeah.
You know what, Michael? It is the pendulum that is swinging around, but this is not the thing that the pendulum can swing back. Right now, everybody talk about the airway orthodontic. What the amazing thing, evolution that is happening in field of orthodontics, in field of dentistry and medicine, although is lacking some subject, but we are in the right track. But this is not the pendulum that, Michael, is going to swing back and say that airway is not important. Mm-hmm. You know what? We were talking about headgear, no headgear, extraction, no extraction. And then the pendulum, after a while, TMJ has something to do with extraction, doesn't have anything to do with extraction. But pendulum change. Mm-hmm. This is not the pendulum can change that you ignore the sleep apnea. Mm-hmm. And you know better. I started talking about evolution. You know that
this is a paradigm shift, I would say, not a pendulum change, right?
That's right. So this is the thing that we need to understand, that when the mind of us got exposed to this and we changed this understanding, we don't have any way to go back and ignore it. But at the same time, the profession needs to understand, dentistry, dental profession, medical and orthodontic needs to understand this is something that is happening to human beings and is not going to go away.
Yeah.
Either you are going to learn and take advantage of it, or unfortunately, you're going to suffer from ignoring it.
Yeah.
And you mentioned about, I have the background in anthropology, and one of the best things that happened to me is exposure to Weston Price. Weston Price, one of my mentors, the issue that he, when I read his books and said that, wow, this is the guy that lived 100 and 200 years ago, but how great mentor has been for me to understand that how evolution changed this thing and what is happening. Mm-hmm. By the way, remember Ohio State University, I got double master in biology and also the anthropology. They gave us opportunity. And then when I had as part of my project, I was looking at the skulls of Adena Indians that they used to live in that valley 2,500 years ago. And we were looking at the concept of brachycephalization, that they were changing their head and how the jaws changing. When I was looking at these massive arches 2,500 years ago, only 2,500 years ago, and then contemporary samples that the jaws are kind of shrinking. So that kind of raised another, red flag and awareness. So I went back and looked at the Australopithecus, the early human beings that they had massive jaws, and they were eating a lot of massive, roots and bones, they're breaking bones, and the jaws were, very, very massive. I'm sure like a chimpanzee or, cousin, genetically, cousin, that they doesn't have a sleep apnea. Australopithecus, I don't think that has a sleep apnea. But at the same time, when we became bipedals and started eating softer food, Homo erectus, Homo habilis, using tools, till Homo sapiens about 200, 300,000 years ago, when you started using softer food, we didn't use our jaws. And then about maybe 200 years ago, even another cultural change, which is pacifiers, not enough, breastfeeding and softer food. And unfortunately, another 45 years, 20, 30, 40 years ago, soft diets, industrialization, and softer and softer food. And now, unfortunately, fast food and processed food, the jaws are shrinking. Our profession needs to understand, and the industry understand, and medicine understand this is evolutionary thing. Our brains are getting bigger or stay the same size because we get smarter and smarter, but the jaws are getting smaller and smaller. That's
kind of rinky, right?
That's right. That's why wisdom teeth do not have room.
Right.
So we are becoming like aliens. You see that through the small jaw. Right. So we need to change our strategy, that how we make these, alien faces that they're developing, how we are going to backward go and make them again people or individuals that they're going to have a stronger jaws, growing jaws, to change them genetically and epigenetically. So hopefully that was that's my understanding. That's why they saw it, either you adapt or you are going to, not progress properly. So I adopted and adapted to this technology, and it was no other choice for me. And I know that you went through the same process.
Yeah. And why do you think it remains controversial amongst many of our colleagues? I mean, I have many colleagues with whom I speak and interact with online, and they still are just convinced that malocclusion is entirely genetic. It's a mom and a dad. There's no role of environment. I mean, the data and the science don't support that theory. They haven't. I mean, people can question Mel Moss and functional matrix. I've yet to see somebody who could really disprove his points. They'll say like, well, I think Lyle Johnson wrote an article questioning the functional matrix. And then Mel Moss, I believe, went back in 1969 and refined it to incorporate airway as part of that, and breathing as part of the functional matrix to help develop the appropriate craniofacial respiratory complex, as the case may be. Yet a lot of our orthodontic colleagues, we study this. We study Linda Aronson. We study Harvold. We study Corcini. We read all those articles in our training. Why doesn't it take, in your opinion? Why do we read about that and then we get out and we just want to just straighten crooked teeth and not try to adjust for these evolutionary problems and these epigenetic problems that we're seeing? Hey, everybody. We all know that we don't learn much about interceptive orthodontic treatment, especially as it pertains to airway. That's why I created a comprehensive CE course that you can access through the doc website. This 26-hour course will transform how you think about and approach interceptive treatment and teach you how to implement airway-focused orthodontic treatment into your practice. Just go to theorthocoach.com and click on the courses dropdown. I'll also put a link to it in the show notes for today's episode. If you're looking for ways to improve the health and truly change the lives of your young patients, then this course is for you. And now back to today's episode.
Lack of science and lack of so one of the things that happens, fortunately, unfortunately, the disease of obstructive sleep apnea is a chronic disease. So it is not something that if you have a sleep apnea, drop dead tomorrow. It's not like COVID. Do you know when COVID happens? In matter of less than maybe 6 months, the whole universe changed upside down. Michael, they closed the businesses, everything upside down. Do you know why? Because it was killing millions of people quickly. The disease of obstructive sleep apnea is killing. It is 1.3 billion people suffering presently, worldwide, but it's not such an aggressive disease that right away. But let's talk about smoking, all right? When the science proved that smoking is bad for you, they don't let you smoke in the, inside the, they kick you out. You cannot smoke in the hotel. You go to the resort, Michael, and you spend $20,000 on the resort. When you want to smoke, you need to go out of the resort, stay front door and smoke, because it is a known fact, is the known paradigm shift, because they know that smoking for a couple of years, cancer kills you.
Yep.
Unfortunately, that relationship and connecting dots is still in the arena of the sleep apnea, and airway is not exist. If by any chance science comes and prove it more, and the understanding is that, I'm sure that it cannot be denied. But we are in the process that hopefully you are going to see it, and hopefully I'm going to be lucky enough to see it. It is changing. Look at this. We have such a strong clinicians. Mariana Evans, right? Audrey Yunes, they go there and they say that, guys, this is airway. We are treating the airway. It's not the whole picture. It's not the whole, it's part of the picture. But it's more understanding. And I'm sure that, innovators like this and great clinicians like, Kevin Boyd, Ariane, and again, we have so many of them that right now they're looking at this. We don't have the complete understanding, but it is coming, Michael. It is in the next decade, 2 or 3, next decade, the situation is going to be completely changed. But you know what? The other thing that is important is,
if I could interrupt for a second on that, what do you think? What role do you think our educational institutions, primarily speaking of orthodontic residencies, and the AAO will play in facilitating that change or obstructing that change? Are they going to wake up, no pun intended, and start to understand what you and I are speaking about the comorbidities of airway disease, about the ability of the orthodontist being uniquely positioned to intercept this at a very young age, absent the fact that we don't get any training in the behavioral management of young kids? That's a whole nother issue, but that's a big part of this, in my opinion. We don't learn how to treat young kids in our residencies. Most orthodontic residents graduate and they've treated 1 or 2 patients under the age of 10 their entire life. So in all of dental school and residency. So they don't know how to treat young kids. But part of that is because the AAO and the orthodontic education programs, they don't facilitate that. They don't promote that. To take it a step further, I think a big part of that is the fact that always follow the money. I hate to be that way, but sadly, that's the nature of things. The majority of orthodontic programs treat patients on state funding, Medicaid or federal assistance, state assistance, right? That's just where they're located. They're providing lower cost care. They tend to treat a large proportion of their patients on state funding from the underserved communities. And those patients go by the HLD index for coverage, which was evolved from the Salzman index, which was, I believe, 1968 in the AJODO when Salzman first published on that. That was born out of a desire to try to quantify what they call a handicapping malocclusion. It was based on teeth and teeth alone. It wasn't based on orthopedics. It wasn't based on jaw growth. It wasn't based on prevention or proactivity. It was based on, can I get these teeth straight now? Do I have to jump in to do something to straighten these teeth now, or get the bite to fit now, or can I wait? And because of that, when a 5, 6, even 7-year-old comes into an orthodontic clinic and they're on Medicaid, if they don't have a crossbite and they have narrow constricted arches, they could have 8 millimeters of crowding in each arch. It doesn't matter. They're not getting covered. They can't score enough. So those patients don't get seen in a residency. And so those docs never get training on it. And what else does that mean? It means our orthodontic institutions are never doing research on those types of patients. It means they're never practicing on those types of patients from the faculty practice side either. So of course, the academic institutions think this isn't a thing because it's not part of their reality. It's not part of their world. Before I turn it back over to you to hear your thoughts on that, I challenge people all the time when I speak and lecture. I say this to groups of orthodontists. Can anybody convince me that if all of a sudden we started having really large reimbursements for treating younger kids orthodontically, say something to convince me that you wouldn't see orthodontists jump behind early treatment if they were going to get paid. Let's just get extreme. Let's just say they took the benefit away from adolescent treatment and put it to early treatment. You think orthodontists are going to change their tune a little bit? I think so. So again, I hate to, I don't mean to flip in saying that, but it's a frustration point for me.
Well, I think that you pointed out in very, very good, example and made it it makes great point. So remember that AAO is representing a community of orthodontists that right now, as I mentioned to you, they're comfortable and the system is setting up. And of course, they're struggling. Mm-hmm. The whole industry of dentistry and specifically orthodontics, because dentists, they can do orthodontics and orthodontics cannot do the crown and bridge. So financial right now is a struggle to run more cases faster.
Yes.
There is no time for thinking. But at the same time in programs, so the issue of the insurance companies, they need to change the paradigm. So it means that, as you said, why crooked teeth are important and it makes or crossbite make them eligible for treatment or not eligible, because it's all dental, is not the medical need. Mm-hmm. And medical insurance in general, okay, we try to be nice. Lack of enough evidence, they ignore the fact, all right? Mm-hmm. They ignore the fact that how important it is. Mm-hmm. But then we need to change the way that we approach it. So yeah, there is no way that medical insurance should pay for straightening the teeth. Dental, they say, is static, is function. We pay $1,000 or $2,000 and it stays the same amount forever. Mm-hmm. But at the same time, in order for medical comes and engage in this, it is important that we have enough evidence. Some of it is hesitation, because if you accept it, you need to pay for it. Of course, it's coming. Some medical insurances, they are now paying for the oral appliances and treatment for the kids. Mm-hmm. It's slowly coming. Mm-hmm. But at the same time, we need to make a distinction, Michael. So it means that not medical insurance, they don't have to pay for everybody that is getting orthodontics, all right? Like medical insurance should not pay for everybody that gets cosmetic orthodontics. Do you agree with me? Straightening teeth is the dental. You have a dental problem. Mm-hmm. We get your, dental insurance pays for it.
Yep.
But at the same time, if the science and evidence support that these are connected, mm-hmm. I have a publication that says that crowding, malocclusion is almost hand in hand. There are two paradigms that they overlap. So it means that crowding and airway issues and sleep apnea and crowding malocclusion, there are two pandemics that are overlapping.
Yeah.
But at the same time, dental insurance pays to this one and medical pay. That's why we came up with bridging the gap. Michael, we need to bridge the gap between dentistry and medicine. And there is something that is very, very critical. So let's look at the maxillofacial surgeons, all right? Because between your between your things that you were mentioning, you also brought it up, how this is going to change. Let's look at the maxillofacial surgeons, the training that they have. A small population of them, Michael, they get MD. You're aware of it, right?
Yeah, sure.
Some of them, they have MD and, DDS and MD.
Yep.
That group, they get more exposure to more complexities, maxillofacial surgeries, MMA surgeries, airway, temporomandibular joint replacement. And as a result of that, now also there is another change. So I don't know, what was your experience in your practice, but in my practice today, if I want to send patient to get MMA surgery, guess what, Michael? The first thing that medical insurance wants to know is that if they have malocclusion, patient can have about 12 millimeter of overjet, they don't give a damn, all right? Yep. They deny it. But if they have the sleep apnea and AHI is over 15, it is almost, positively, we know that they can approve.
Yep.
What does it mean? Because medical insurance is still with the unsubstantial evidence that exists. They know the impact of it. Mm-hmm. They know that if this kid or this young people or this adult patient with AHI over AHI, 15, which is excused because even milder AHI can hurt you. But now it's 15.
Right.
So if the 15 is not treated and you stop breathing 15 times per hour, is going to hurt your heart, your brain. It creates a individual that this individual now needs to pay over $200,000 lifetime to get treatment. And guess what? The insurance companies are going to suffer. So medical insurance companies are getting smart. Instead of paying 200 grand for lifetime of this guy, individual, to get heart attack and a stroke, which is much, much more expensive, millions of dollars, pay about $20,000, $30,000 and get this MMA surgery done.
Right.
So what I'm saying, eventually we are going to have a little bit of separation. There is no way that cosmetic orthodontics, the way that it is, should go away. No, we need to have a group of clinicians that their expertise is making teeth straight and everybody smile and have great laugh and great smile and confidence. But at the same time, there should be a group of universities, programs, institutions that they come and educate them, like orthodontists or dentists. Now they are getting the MD and DDM or DDS education. And I had that 1 year extra instead of 2 years. I had 3 years of education. I got temporomandibular joint, airway, some of those, and I educated myself later. So eventually we are going to have that distinction. Orthodontic, the way that it is not going to go away and shouldn't go away because we know. All right. So AAO, which is representative, that group of clinicians that they have majority right now, they should feel not threatened. But at the same time, they need to allow for the separation, just a little bit of branch, maybe super specialty of group of orthodontists. Because, by the way, Michael, I'm prejudiced. Orthodontic is the most powerful industry and also modality in the field of dentistry and medicine that can treat the sleep apnea. All right?
I agree.
I am prejudiced about that because I experienced it. Right now, we can cure the disease, the severe sleep apneas of 175 AHI. That medicine cannot do it. We are part of the physician. We are doing this. So medicine needs to come and look at this carefully. But we need to have verbiage, vocabulary, nomenclature that is going to separate us a little bit. And we don't want to call it cosmetologists. That's insulting. No, it is what we call is cosmetic orthodontic. Teeth get straight and people emotionally and functionally, jaws are going to get healthier and they're happy about their smile. They don't suffer from the, hey, look at the crooked teeth and then pay attention to crooked teeth and the guy is, But at the same time, the life-changing impact of the airway orthodontics and what we can do as orthodontists that medicine by itself cannot do it is very, very important. That's why the nomenclature is changing. There are concepts like frontodontics, orthotropics. Do you know, Michael, this is the cry of the community for something new, right? Something is new needed so we can change ourselves and separate. So if medical comes and look at it, says that, no, we are not going to pay for orthodontic because make the teeth straight, but we are going to make the orthodontic if you prove that patient has a sleep apnea. A sleep apnea has comorbidities of ADD, ADHD, heart attack, and stroke. We pay for it. So as orthodontists, So this is very, very unfair also. I want to just open another concept.
Before you do that, if I could interrupt 1 second on that. So I agree with a lot of what you said there too. And I thank you for laying that out. One thing on OSA that I think it's hard, and we've talked about this, because of the lack of access to polysomnography in children, we don't have enough sleep labs, we don't have enough sleep physicians to read these tests, and the inaccuracy of the tests, the one night effect of Yoon, Jane, and Shapiro that they published on in Sleep Medicine Reviews in 2012. We know that traditional labels of AHI, especially in children, is not all we can use. It's not that polysomnography is irrelevant or that you can't glean insights from it. It's just that to make it on a one night in a sleep lab, and I've told this story a ton of times, but I've had patients go to the sleep lab and they come back and they have an AHI 0. Mom will show me a video of the kid suffocating all night long, and it comes back with an AHI 0. And I've had the times where the parents, this one in particular, mom said, oh, they woke him up at 4:30 and stopped the test. he never got in deep REM. I mean, who knows what time he actually fell asleep? He's hooked up to all these wires. He already has the behavioral issues like you talked about with Ryan, right? He's got ADHD. He's all over the place. He's a restless sleeper. That kid never got in deep enough sleep to have, I mean, he was having obstructive hypoventilations, but he was mostly not having, clearly by the test, he wasn't having apneas or hypopneas of long enough duration or successive breaths. So I do feel, and I just want to say, I love what you're saying about the nomenclature, because I feel we need to start to find a way to define, and we don't have it yet, to define pediatric sleep disordered breathing, as I call kind of the mouth breathing and the snoring that we see in these younger children, the proverbial canary in the coal mine. We have to have a way to quantify that to the medical establishment or insurance establishment to say, hey, look, we have the literature, and it's all over the medical literature. I mean, David Gozal's been talking about this. His episode will be airing similar time to yours. I mean, we've been talking about this for decades. So we know the comorbidities. We know the neurocognitive, cardiovascular, behavioral comorbidities. Again, setting aside even the craniofacial growth and development issues. So the tough part is, we don't have wearables yet for kids, although I've been told by a couple of recent guests in the sleep world that there are some sleep physicians that have been on. We're getting there. We're getting close. And I don't know, could you see a day maybe where we have the oxygen, the O2 saturation levels, the hyperactivity levels, because let's face it, ADHD is a diagnosis it's used off the Conners rating scale. Typically, it's a subjective diagnosis. They don't take a test, right? There's no genetic analysis for it. You're not going and getting a ADHD score of 10, right? I'm just, obviously it's just a random example, right? But there's no score for it yet. Medical insurance will cover the treatment for that. So I don't think we have to hold ourselves to a standard of a polysomnography in a sleep lab, which we know is very flawed. We just need to develop the nomenclature, as you said, to say, hey, look, when we see these certain comorbidities, we do it with heart disease, right? If someone has elevated blood pressure, we don't wait for the heart attack, right? If someone has elevated A1C, they get medical coverage to go on meds for that. We don't wait until they're full-blown type 2 diabetic. So why is it such a heavy lift to take the literature and the data we have, where the science is very strong, and show the long-term projection for these kids? Because there's millions of Ryans out there, right? And then there's millions of Ryans who are worse off, who never got the care they need and deserve. Why are we having such a hard time proving this?
Because we are in transition, right in the middle of the transition, and the transition already started. So as you mentioned, the variable for the kids. So first we need to diagnose it. How complex was the diagnosis about 5-10 years ago for kids? You need to wait 6 months. The kid goes into the sleep test. They do the polysomnogram, a lot of wires attached to the kid. The first night effect, the kid cannot sleep, doesn't show the sleep apnea. Okay, doesn't have a sleep apnea.
Right.
But today we have rings, we have wearables, we have owls, we have sleep image rings that is so easy to screen them. But one of the things so in the diagnosis, we are almost there. We are not quite there. We are almost there. There are a lot of variables today. That's the great news, Michael. And the scientists are helping us to develop this even better and better, that in one night, I give the ring to the patient. They try it. Siblings can share it. Next day, I know that they are red flag. They have airway issues, sleep apnea, and then we send them for further information. That's number one. It's coming and is there. I'm sure that, Michael, in 5 years, we are going to be much more advanced than we are right now. And do you know what? The public awareness that now the Apple Watch is looking at oxygenation.
Yes.
I bet these scientists are going to creating Apple Watch that is going to be like a wearable sleep apnea and monitoring. So that's number one is coming. But number two, the other thing is that, is the instrumentation, all right? Instrumentation meaning that making the appliances that the kid at age 3, 4, later can take advantage of it. By the way, we can go to intrauterus stage of the, and prevent it. This disease is preventable.
Yeah, Uma Katwa, who will be coming on as well. I don't know if you know Uma from Boston Children's. He and I were just on a discussion a couple weeks ago on this, and yes, I mean, I pause on that for a moment because some people hear you say that, Joseph, and they're like, "Give me a break." You know, the orthodontic tooth straightening mind would say, "What? No, the medical community knows this. We're the ones as orthodontists that I don't know if we think we know more than we do. I don't know what it is, but just we've never been exposed to it." But you're 100% right. There are even people, and Uma's talked about this, getting in Cleet Kushida at Stanford as well, evaluating the pregnant mother and her sleep, because it's going to oftentimes have an epigenetic effect, and potentially it's going to ultimately have an effect on that child. They're determining if the mother is suffering from sleep apnea. So it can even go in utero, not just to the fetus in utero, but it can actually be mom before mom gets pregnant. Make sure mom is a good breather and is sleeping restfully. I mean, that's how we have to think about this, right?
That's right. So that's the thing that, again, is preventable disease. When Ryan's, my angel, Jenna, his wife, got pregnant, we were checking her, monitoring her. We cured her sleep apnea, both for Ryan and Jenna. And then when she got pregnant, we were checking her sleep apnea. When she gained weight, be sure she had the oral appliance that is preventable, either CPAP so is it preventable, because we know that lack of oxygenation can create, issues for the growth and development, small jaws, but we don't have time to go through that. So we need to give the instrumentation and understanding that, the orthodontists can benefit from it. So now they have equipment, they can use it. And this is going to be intrauterus to age 100. Mm-hmm. We have A to Z plan, which is a medical and dental, meaning that you know about Inspire, you know about the Genio that, is advancing the tongue in order to manage. Those are all should be part of the curriculum, all right? Mm-hmm. So it means that medical education that I mentioned to you, maybe 1 or 2 years, that dentists or orthodontists that get 1 more year of the education in college or dental schools, make them aware of the medical. And that's why when we wrote the book, and I send you the book to study it, mm-hmm. It took 7 years. First of all, I went to this room. This is the room that I lived 7 years, Michael. Right?
I believe it. The book is amazing. It really, I mentioned in the intro, it is amazing.
Days. Yeah, 375 days a year with no break, not 1 day of vacation. And it took 7 years to gather this information, put medical and dental, and develop this technology that is A to Z, that understanding. So what I was saying, we need to give the orthodontists and clinicians interdisciplinary approach. All right. Yes. So it means that it's not just dental, it's not medical, it's a combination. Yes. My functional therapists, sleep doctors, orthodontists, surgeons, ENTs, all they need to work together. And guess what? They need to make money or they're not going to do it.
Yes, right? It's true. I'm glad you said it, because people don't want to say that part, but that's true.
If we cannot make them profitable, nobody is going to do it. Yep. Right?
Yep.
I mean, I have a kind heart and you have a kind heart, right? But not everybody, it is drawn to this understanding based on kind heart. It's a business. It is a business. So they need to see less number of patients. We need to make it more profitable per person. So the person that, or the clinician that see 100 patients a day or 80 patients a day cannot make it medical and spend more time with them. So you need to make distinction. If you are going to treat the airway orthodontic patient, so you are going to get more value per hour, right? Yes. So you're going to compensate for the hour. So that's the important thing. We give them the instrumentation. We allow them to make it profitable. And at the same time, it is working together. We need to give them the confidence that orthodontist now goes to ENT or to a sleep doctor and say that, guess what? I have very profound knowledge about this. And it's a profound knowledge, Michael, because it's the combination of science of ENT, systemic health, oral medicine, and oral, dental sleep medicine, and medical sleep medicine. So this combination in a year or two needs to be educated to these orthodontists and instrumentation, giving them for the diagnosis, treatment, and the confidence that sit on the same table, say that, ENT guy, if you cannot do this and parents are worried about removing tonsil and adenoids, guess what? I can expand the jaws right, properly, and get this under control, right? We don't need to jump and remove tonsil and adenoids. But orthodontists needs to have enough diagnosis, instrumentation, knowledge that sits on the same table, say that as good as medical and maxillofacial surgeon, that is medical degree and education, I'm going to come and participate in this game, save lives, and make smiles more beautiful. How about that? Right?
I completely love that and completely agree. And that's the paradigm shift that I feel like orthodontists can and should be in the driver's seat of all of this. We are so uniquely positioned. And it's funny, a lot of times, because I work with a lot of pediatric dentists and general dentists and orthodontists on helping them understand all of this. And a lot of orthodontists get frustrated saying this isn't a thing. And why do people keep doing this airway thing? And I try to convince them, do you understand that we are the ones that should really take the ball and run with this based on our background and our knowledge? And do you understand that most pediatric dentists and general dentists, many of whom listen to this show and do this, didn't get into this because they wanted to take the orthodontist's work. They didn't get into this because they wanted to make more money. They got into, as you said, if you start getting into this and treating patients earlier, proactive with more advanced techniques and technologies, because the reimbursement hasn't come along to back up all that extra diagnostic time and everything else that's involved, you don't make more money when you go from seeing 80 to 100 patients a day straightening teeth at $6,000-7,000 a pop to all of a sudden having to reshape and reframe your whole practice into a proactive, more medical, communicative practice with other medical providers, less siloed. It's just not true. So the whole thing of you're doing it for money is false. I've had a lot of pediatric dentists tell me I was making a killing doing pediatric dentistry, restorative sort of drill and fill. But once my own child started having a problem with airway, or once my friend's child did, and I saw them, I started looking more into it, and I started asking orthodontists, can you do something about this? And the orthodontist said, they're too young. They'll grow out of it. And I've had general dentists say, I make a lot more money putting crowns on implants than I would ever make doing some intraoral appliance on a 4-year-old. It's not even close. But I can't, now that I've seen it, because I'm a healthcare provider, because I care, because I'm compassionate, I can't turn these kids away. And the darn orthodontists just won't do it. So, and I know I'm generalizing there. I have a lot of orthodontists who listen to this show who do it. So for all of you out there that fall in that, I apologize. I'm not pointing fingers at you. I'm speaking kind of writ large about the profession, that there's still this general sentiment that you don't see patients before the age of 7. I hear people say all the time, or I see it on our online groups, treating a patient at the age of 4 is malpractice. What are you talking about? That doesn't even make sense. There's no data to support that. There are no randomized controlled trials on the time to start orthodontic treatment. It's all retrospective data. It's all based on convention of timing, right? And even the AAO on their website says, you don't wait until 7. 7 is the last point at which they should be seen. They can be seen prior for other issues. And 2 of those issues, one of them is mouth breathing, and the other one is altered facial growth. So the AAO says on their website that if you're a parent and you see a child mouth breathing or with altered facial growth, take them to the orthodontist before the age of 7. But the orthodontist is going to tell you there's nothing they can do. So I completely agree with you.
Yeah, but the thing is that, again, ultimately is that if the clinician cannot make it and they struggle with the financial part of it, they're not going to do it. Yeah. So we need to make make them the way that the clinician, and pedodontists are the most important. They are the ones that they have more capability to manage these kids from age 2, 3, 4. Mm-hmm. But orthodontists that they start earlier also is important, because there's something that pedodontists, they cannot do it. But they need to be allowed to get some part from the medical insurance and some part. Yeah. That's why the technology that we have created, Michael, and with the help of Ryan, we developed this company, ApnoMed, that we created this understanding, the book, the education, that we educate the clinicians about this, but then we give them the opportunity to get reimbursed from medical and dental. When I treat the patient, and we need to have the advanced technology. It's not just expanding the jaws properly. I mean, recently I had the great podcast between two great surgeons, Michael. These are the sleep, these are MDs, maxillofacial surgeon. Reza Mowahed, and I'm sure Reza. You heard about
Reza. Reza and I are friends. Yeah.
And also, Sam Bobak, two great surgeons that they treat the sleep apnea, and they both say that the system needs to be more perfected. We need to have capability of expansion surgeries and advancement surgeries to treat this, and the technology that we need to have again should be A to Z. And we have it right now, minus tracheotomy, that is a permanent treatment for sleep apnea. We have step by step that we can work with medical doctors and alongside with the medical doctors and defeat this disease of airway issues, mouth breathing, and sleep apnea, even with the most severe. That's awareness that we are trying, and the book is trying, the pediatric treatment of sleep apnea with Teledontics Telegnathics, trying to bring that awareness that such a science existed, such an education is there. But you know what is not good enough, Michael? Till we get it to university, and it's going to be taught at universities, and it's going to be evidence-based, not just one or two. Or, of course, we have trained over 500 clinicians right now in the United States that they can do this. But we need to have army of the clinicians that are equipped with this, because there is a pandemic of 1.4 billion people suffering from it. They need to make money. They need to be comfortable. They need to get medical and dental reimbursement, so they start doing it. That was my answer to your, loaded question.
Yeah, no, I appreciate that. And if you would talk a little more about teledontics and telegnathics, because a lot of people, I think, hear that and don't know what it is or what it means. So explain that a little more, if you would.
So, okay, Michael, 7 years, remember 7 years? And the concept that, orthodontics has a lot of good things. And I mentioned to you, I'm biased, prejudice is the most powerful. But at the same time, there is a misunderstanding during years of this, developing and evolving. When Dr. Engel came up with the first concept of, Pierre Fauchard and then Dr. Engel, and started talking about orthodontics, they did experiments. And I'm sure that the first case that, was done by Dr. Engel, he didn't start extracting teeth and making the rest of them straight. He started, this is kind of interesting that one day he saw one of the patients in the, street. He looked at his mouth that he expanded and it stays like that, and that changed his paradigm. So, but then during the evolution of the science and knowledge, you remember Aborigines that Dr. Weston Price showed his pictures that the teeth are crowded. At one point, there was a misunderstanding. So maybe this crowded teeth, they should be extracted. We look at the symptoms. We didn't look at the concept and what is causing factor. This is the generation that start exposed to the industrialized food, processed food. They couldn't breathe, started mouth breathing, malocclusion, craniofacial, the maxillofacial changes, and that created the crowding. So instead of extracting and taking care of the symptoms, now we understand that the causing factor is airway. Mouth breathing is a big problem. We need to expand. So we need to create clarification. The appliances that created the concept of the headgear pushing everything back. If the lower jaw is not growing because of clinching and grinding because of bruxism caused by sleep apnea, we shouldn't hinder the growth of the upper jaw and bring it back, which is called headgear effect. So if you're treating a sleep apnea, we need to come up with the new nomenclature and understanding. The appliances that out there, functional appliances, and there are 130 of them out there, and they look like the same as, oral MAD, mandibular advancement appliances like HERPS is a functional appliance, and also they use it for management of sleep apnea. guess what? The ones that have headgear effect that cannot be used for management of sleep apnea because it creates retraction of the upper teeth. So we need to create some clarification. I mentioned to you there have been trials, efforts, orthotropic.
Talk about that word. I'm glad you revisited that, because just the word orthotropic is going to make a lot of our colleagues turn the episode off. I mean, the word orthotropic itself, I don't necessarily understand why, but it is literally a trigger word for many of our colleagues. So if you wouldn't mind, before you continue on the Teledontics Telegnathics, what is that about?
Well, it started with Dr. Mew, of course, and it created a lot of hassle because it point finger to orthodontists, which is wrong. All right. Mm-hmm. So meaning that accusing orthodontists of doing wrong, that pushing the upper jaw back. So the concept is not wrong, and taking advantage of that, make more money, is wrong too. Mm-hmm. So as a result, that's why they hate to hear the term for, orthotropics, because it accuses orthodontists harming kids or, individuals. But at the same time, what I'm saying, orthodontics, the way that it is for treating, expanding the jaws and making the teeth straight, is valuable. But there are some concepts that we needs a little bit of purification. So we are treating the airway patients that are susceptible, Michael. This population are more susceptible than regular. You can use functional appliance on non-susceptible patient and nothing gets hurt. But then this population, small population, are vulnerable. We need to purify the understanding and application of the appliances. So on the kid that has a small lower jaw, because clinch and grind, because of bruxism caused by sleep apnea, jaw is small, we cannot put the Herps appliance because it has a headgear effect. Mm-hmm. So any appliance that has headgear effect is not purely acceptable for this population of patient. Maybe you can use it for somebody that, it is not as vulnerable. Mm-hmm. Headgear, functional appliances that have headgear, maximum anchorage extraction that brings the front teeth back. Mm-hmm. Those are the things that we need to think a little bit more carefully on this vulnerable population, not on every patient, but on vulnerable population. That's why the term Teledontics Telegnathics, and of course, you remember, publication by 2019, white paper of American Association of Orthodontics. Mm-hmm. They said that, this area that causes sleep apnea is, from the nostrils to the back of the, throat down to the, and that's not exactly craniofacial, the name craniofacial doesn't apply to it, but we need to manage this for treatment of sleep apnea. But then in that article, also they said something else. Telegnatic surgery, MMA surgery, bringing both maxilla and mandible, maxillary mandibular surgery was mentioned as the most effective surgery for treating sleep apnea. Every maxillofacial surgeon that has a medical background, they know about it, they know the value of it. Mm-hmm. They know that, bringing the jaws forward has some impact on improving and setting the mandible back is deterioration and declining the airway. So telegnatic surgery was acceptable term. We need to make it the way that, so orthodontic, orthognathic surgery, cosmetic, straight jaws, straight teeth, cosmetic approach. But at the same time, telegnathics, that is a MMA surgery to treat the sleep apnea. Teledontics, the term is using non-constrictive, non-restrictive, very, very light force. So we cannot put pounds and 10 pounds, 4 or 5 pounds of force to move the teeth. Light force, which that's why aligners are perfect instrumentation for this terminology. Non-restrictive, don't bring it back. Don't restrict the airway. Everything is about expansion, airway expansion, moving the jaws and growing jaws. We have technology to grow the jaws away from the base of the skull to open up the airway. That's why teledontics and telegnathics is the new understanding, and it's just new nomenclature. Mm-hmm. Unrestrictive, non-constrictive approach to orthodontics. All right? Mm-hmm. Simple. Mm-hmm. And we have the mechanism and technology that we can do that from age 2 to age 80, 9 years old, and it's very simple, all right? And guess what? We have developed appliances that is called ApnoDent, ApnoTX, different variety for open bite, closed bite. So not only treat along with aligners or braces or expanders, they help the jaws, they grow without having the headgear effect. So the technology, again, simple, interdisciplinary medical and dental approach, bridging between medical and dental. And some of this is paid by medical, some is paid by dental to correct the malocclusion, dentofacial discrepancies to improve airway number 1, temporomandibular joints, and dentofacial discrepancies. Hopefully that answered the question.
Beautifully. Yeah. Thank you for explaining that in such great detail and so clearly, because it does. Before we finish up, I want you to talk about, as part of that, one of the cool things. I know Rez is doing this as well with the osteotomy in the mandible, and just go into that a little bit, what you're doing, because I'll kind of color the background a little bit here. First, we are always taught in orthodontics, which is not true, that you should never expand the mandible, the mandibular arch. What's happening there is the mid-symphyseal suture, the midline suture in the mandible, fuses around birth-ish, right, within the first, say, your first year of life. So when you're going in on patients any older than that, the midline suture is fused. Very different from, for those who maybe not be in the field who are listening, very different than the maxilla, which the suture maintains patency for, in adulthood, really, there's some element of patency, but it's widely patent when the child is young. So that's why you hear about upper expansion more than lower expansion. Now, I talk a lot about how lower expansion from a dental alveolar standpoint is so critical, because many of these cases, to take us back to where we talked about earlier with the HLD index, those cases without the crossbite, those cases are narrow, meaning they're crowded because the maxilla is narrow and the mandibular arch has just caved in to meet this narrow maxilla. So why do we only try to expand the upper a little bit? Why don't we upright the lower teeth, dental alveolar? In that case, we're going to get to your situation in a minute. You're not getting sutural expansion in the mandible. You're uprighting the teeth, getting dental alveolar expansion and tipping, which you need, level that curve of Wilson. You're essentially giving the patient a crossbite, so to speak, but at the same time, you can do it concurrent or after, you expand the maxilla and you get it outside the mandible, and now you've normalized the transverse for that patient. So that's just kind of on the mandibular expansion. There are articles on this that go back. Schwartz and Gratzinger were developing and talking about this in the 60s. We did lower expansion, the Arnold expander. There's all been the bihelix. There's been tons of research on this. There's a great article, 2006, AJODO, McNamara, put out with Bichetti or maybe Frankie. A few of them put this article out that did a really nice study over 20 years looking at lower expansion or upper expansion alone, no treatment in upper and lower expansion, and concluded that doing both is far superior. So I don't know why expanding the lower arch is controversial. The only thing I can think is people think, oh, you can't expand the lower. A lot of little studies on like expanding the canine width, I think, cloud people's judgment. That was Little and Shapiro, I think, did a lot of those. That was in like the 80s and the 90s, a lot of those studies. They were looking at only the permanent dentition. They were literally looking at people blowing out teeth that were fully erupted. We're talking about going in young in the primary or mixed dentition and developing the structure. We're not talking about a debate over whether you can take canines that erupt at 25 millimeters apart and put them at 35. We're talking about going in and taking a collapsed arch of a young child and developing it. You take it a step further, and it's really cool what you're doing. Tell us about a way you can get actual orthopedic expansion of the mandible, and not in the way a lot of people might think.
So the thing is that one thing that you mentioned is changing the epigenetic, meaning that if you start these kids early, prevent it intrauterously, and then when they're growing, grow their jaws wider and longer, we don't need this technology. But at the same time, remember A to Z that I mentioned to you? Mm-hmm. We need to have very advanced technology that we can expand both upper and lower jaw and advance them, either non-surgically when the child is growing, mm-hmm. but after the growth is done, we need to have mechanism to, grow the jaw. And MMA surgery is great, but not every individual can go through the expense and complexity of MMA. So as a result of that, and it's something that is amazing because it seems that it's close to doesn't exist. It cannot be done. Michael, when in late 1800 and early 1900, you remember and probably you heard that cardiac surgery was forbidden. Nobody touched heart or doing the heart surgery, right? For first time, Johns Hopkins University came and said that is doable. The baby blue syndrome, remember the one that has the hole between left and right, ventricle, that the baby blue mixture of the hypoxia oxygen and oxygenated, and they were killing the kids when they were 3-4 years old or older suffer from this. They changed the paradigm, right? You didn't shift the pendulum, they changed the paradigm that cardiac surgery is possible. When Lazaroff came up with the concept of distraction osteogenesis and made the arm or leg of somebody longer, at the time they were said that is impossible. Guerrero in mid-90s came with the idea of symphyseal distraction osteogenesis, and they did a couple of them with drawing mechanic that created joint damage, but at the same time that science is improved. If you expand the maxilla, it's like an opening is the jar and the lid. If you expand the opening of the jar, maxilla, unless the lid is expanded, they're not going to fit together.
Right.
The meaningful expansion of the upper jaw is not 2 millimeter, 3 millimeter. Based on our experience, 6, 7, sometimes 10 millimeter, right? If you cannot have the capability of expanding the mandible, if Reza Mowahed and Sam Bobak, they don't have the capability of helping to expand the lower jaw and upper jaw, we cannot get the meaningful correction of the crowding and improvement of the airway. So as a result of that, we have done several hundreds of the maxillary expansion, but we have successfully managed to develop a technology that couple of hundred of these cases of mandibular expansion successfully done. Some of them are as old as 23 years out of the treatment, successfully cured sleep apnea. Is very, very profound. As Reza Mowahed and Sam Bobak, they mentioned, expansion of the lower jaw is the most effective way to be unanimous with the upper expansion in the first stage, and sometimes sleep apnea gone in that stage. We don't need to go maxillary first MME, maxillomandibular expansion, which requires mandibular expansion, and then the next stage is going to be MMA. So as a result of that, I have to do it. It was another have to do it, Michael. And it started with Dr. Arnett's course. Remember I mentioned to you?
Yep.
So we had a case that had 4-body extraction, had a sleep apnea, and the surgeon, Dr. Trimble, is asking me to extract one more teeth to make room for the MMA surgery. And I said, this beautiful lady does not have enough teeth and you want me to extract one more central? So I took the course to Dr. Arnett. Arnett looked at it and said that, Joseph, you're screwed. You don't have any other option. I said, you know what? No, we can do it. So we developed this technology for that specific patient that is published now several times 23 years ago, and we expanded the mandible. But by the way, we don't call it MSDO anymore, mandibular symphyseal distraction osteogenesis, because we experienced that we can do it off-center. We can put the osteotomy between lateral and central if there is a little bit of asymmetry. But I'm glad you mentioned it. Remember, A to Z is one of the most effective surgeries to expand the mandible, expand the maxilla. It takes about 4 to 6 months start and finish the process. It is complex. I cannot say that it's easy. It is complex. It needs a lot of expertise because damaging the lower teeth, those things can happen for newcomer. But we have done over a couple of hundred of these have been true. Over 161 of them successfully done. And Michael, we lost just 2 teeth.
Wow.
Right?
Amazing.
This is, amazing. Baby blue syndrome, Do you know how many kids they were sacrificed in the beginning till this science of heart surgery was established? It is very predictable. That's why we get a lot of these individuals, especially young people, they hear it in the social media. They said, well, they look at our website and see it looks scary, but look at 100, over 150, 60 cases that are out there successful over 23 years. It is predictable science. It is enhancing the expansion of the upper jaw and also enhanced with the MMA surgery. The success for cure sleep apnea can be pushed over 90.3%, not 100%, but 90.3%.
Wow. It's so great. I really appreciate you taking the time to go through all this in such detail. Before I kind of close here, how can people find you and learn more about you? The book, Pediatric Treatment of Sleep Apnea with Teledontics and Telegnathics, I have right here for anyone on the video feed, is outstanding, extremely thorough. Many of the co-authors are friends of mine, been on this show, leaders in the field. So really, really great job to you and Ryan putting that together. But how can people find you, and where's the best place to go to find the book as well?
Okay, so by the way, the book is the concentrate of 30 clinicians, scientists, clinicians, including the input from Dr. Gimino, that developed this, introduced this technology, validated by Johns Hopkins University, and about 10 academic institutions like Johns Hopkins, Stanford, University of Washington. These are clinicians. You can buy the book on the what we call a CRC Press. CRC Press is a medical publisher of the book. Is a medical book. It's not the dental. It's medical and dental, but published by medical publisher. Also, you can buy it on Amazon. But well, we have not been keeping this science to ourselves, Michael. So we have ApnoMed educational system, ApnoMed that is going to have appliances that develop, but comprehensive treatment seminars, ctseminars.com is the educational community that you're educating these. We have about 8 seminars per year, interdisciplinary orthodontists, dentists, maxillofacial surgeon, myofascial, all these clinicians that they help treating sleep apnea are part of the group. Is a teaching system that clinicians and individuals, the book is easy enough, Michael, that even the layperson can read it and understand the concept and find, and it is the completed 20 cases. That's why also another reason that took 7 years, it took so many years to complete these cases. We did not have a case that we didn't diagnose, treat, complete the diagnosis, be sure sleep apnea is gone. This is not just cases that shows that the teeth expanded. The sleep apnea is gone, temporomandibular joint is cured, and dental facial improvement is there. And then the second volume of the book that is coming hopefully next year is on the adult population. Altogether, 64 clinicians and scientists participated to writing these volumes, clinicians like Dr. Kevin Boyd and some other ones. But anyway, is available to other clinicians and available to public.
It's such a great piece of work. And I really do sincerely want to thank you for your dedication to this. You're a warrior. You're an innovator. You've fought a lot of battles. I know from being on this side of it, it's not easy to speak the way we speak and fight for this paradigm shift. Again, I love it. We were so on the same page with that. This isn't a pendulum swing. This is a paradigm shift. And you see it so clearly. You have such a clear vision of that, and you don't keep it to yourself, even though, as I said in the beginning, you're somewhat understated. You're not looking for the big billboards and to have the spotlight on you. Yet you're so consistently moving the ball down the field and kind of pushing that needle in the right direction. We need people like you, focused in science, focused in data, with the knowledge and the ability to do this. So keep fighting. I'm here with you however you need me to help you on your journey. It's an absolute pleasure to get to know you and Ryan through this. And I'll put all those links in the show notes for people to be able to reference that as well.
Well, thank you very much, Michael, for opportunity. Again, it is a science that is developing. We don't have the 100% of the answers, but at the same time, we have almost over 90% success and answer the question that is there. Michael, let's save one life at a time. Yeah. All right. Orthodontics is the most powerful dentistry and medical, and we are going to conquer this pandemic of sleep apnea. It is already there. It's just a little bit to go. So governments, medical establishments, dental establishments, they need to understand it and come and help us. Thank you very much for the opportunity.
I love it. My pleasure. So great to have you. Dr. Joseph Yousefian, absolute pleasure.
Thank you very much. The same here.
All right. Bye. All right. I'm going to hit stop record here. That was great. Thank you for tuning into this episode of the Doc Podcast. Be sure to visit theorthocoach.com to get access to ADA CERP recognized CE courses or to schedule a private one-on-one coaching session with me. Also, if you know of someone who would make a great guest for this show, or if you'd like to be a guest yourself, please email me at drmike@theorthocoach.com. And be sure to join the Doc community on Facebook for more great content. Thanks so much for listening, and always remember, you have been blessed with the ability to do amazing things.